Hello, my name is Marek Jutel, and I am the current president of the European Academy of Allergy and Clinical Immunology. I would like to explain today the role of allergen-specific immunotherapy in the treatment of asthma. This is an absolutely basic treatment modality in an allergy office to treat allergy. However, it is still disputable what was the role of allergen-specific immunotherapy in the treatment of asthma. And we believe that, in fact, in allergic asthma with the T2 type inflammation, allergen-specific chemotherapy plays a very important and even fundamental role in the management. As allergy impacts asthma control and future risk, there is a large number of studies that show, for example, that more than 85% of children with severe asthma are atopic. Children with severe asthma have high allergic burden. Emergency room visits and hospital admissions are increased in children who are sensitized and exposed to high levels of inhalant allergens in their homes. And the level of specific IgE is associated with an increased risk of severe asthma exacerbations requiring hospitalization. And it has been also shown in a number of studies that the risk of developing asthma, the greatest reduction in lung function, and risk of exacerbations is associated with both early and multiple allergic sensitization, as shown here in red. So in the allergen-specific immunotherapy guidelines in the treatment of asthma that have been published by the European Academy of Allergy and Clinical Immunology, a lot of attention has been paid to evaluation of the impact of allergic sensitization on asthma symptom and control. So the diagnosis of allergic asthma is absolutely essential to consider adding allergen-specific immunotherapy to regular control or treatment. However, there are some requirements, so asthma should be controlled or partially controlled, and as stressed a moment ago, the relevant allergen, which is the driver of symptoms and control, should be identified. What can we expect? We expect a decrease in symptoms and medication with a potential for steroid-sparing effect, allowing step down to control asthma, and potential benefit in reducing the risk of exacerbations and improving lung function and decrease air activity. And you can see here, this is an example in injection immunotherapy, the subcutaneous immunotherapy kit with mild allergens in asthma, both in the pediatric population and in the adults. It has been achieved after 3 years of treatment of children with allergic asthma that 60% of these children did not require inhaled glucocorticosteroids to maintain their asthma control. And in this study in adults using the same product, also injection immunotherapy, up to 80% of individuals who were previously on inhaled glucocorticosteroids did not require continuation of this treatment after adding allergen-specific immunotherapy. These were the controlled studies, the RCT, randomized controlled trials. But also in the real-world evidence, this is very important for us. This one study with injection immunotherapy as well, which included both severe, moderate, mild, and intermediate asthmatics with poor, partial, good, and complete control of their asthma. Adding of allergen-specific immunotherapy resulted in decreased numbers of healthcare center visits and especially emergency room visits. So also real life shows a great benefit of allergen-specific immunotherapy in the asthma treatment in selected individuals, especially using house dust mite allergen, but also with seasonal allergens. So in summary of our guidelines, of course, we should add allergen-specific immunotherapy in controlled asthma. There is some controversy in severe asthma, partially, and uncontrolled asthma. In the uncontrolled asthma, we should achieve asthma control and then add safely allergen-specific immunotherapy. However, in partially controlled asthma, we can have the same approach, but we can also, in selected individuals, especially in the centers that are experienced and equipped, it is possible to add allergen-specific chemotherapy to facilitate achieving asthma control. And this is the summary of our guidelines, which very much advocate for the broader use of allergen-specific chemotherapy in the treatment of asthma with allergic background and with the proven T2 type chronic inflammation. Thank you for your attention.
Welcome everyone. My name is Ivone Guiluz. I am currently the Secretary of EAACI Asthma Section, and I am also an allergist working at Hospital Regional Universitario de Málaga. Today I want to share with you several relevant aspects of asthma and COVID-19. We know that there is a relationship between viral infections and asthma exacerbations. The bronchial mucosa of healthy subjects is populated by different types of dendritic cells. When rhinoviruses reach the airways, they trigger a strong release of type 1 interferons from bronchial epithelial cells and dendritic cells, which mediate functional antiviral immunity. That's why healthy subjects don't develop symptoms in the lower airways from rhinoviruses, they only experience common cold. On the other hand, the bronchial mucosa of asthma patients, of most asthma patients, displays a type 2 inflammatory milieu, including type 2 cytokines and dendritic cells harboring IgE on the cell surface. When rhinoviruses reach the airways, the bronchial mucosa of asthma patients is not able to release high amounts of interferons. There is very weak release, and it is not enough to mount functional antiviral immunity. That's why asthma patients experience exacerbations. Considering this relationship between viruses and asthma exacerbation, one of the first questions that arose was whether asthma was a risk factor for COVID-19. Asthma was absent among the comorbidities of the first series of patients published with COVID-19 or COVID-19 related death. Later on, 2 large studies were published. In the EAACI studies, data from more than 200,000 adult patients with COVID-19 admitted to hospitals was analyzed. Asthma prevalence in this population was 14.5%, which is way higher than asthma prevalence in the general adult population. Asthma was identified as a risk factor for admission to intensive care unit in the context of COVID-19. Also, asthma requiring triple therapy of inhaled corticosteroids, LABA and LAMA, was a risk factor for COVID-19 related death. On the other hand, the Open Safely study, including data from more than 17 million adult patients attending primary care services in the UK. 11,000 COVID-related deaths were identified in this population. Asthma was among the risk factors for COVID-19 related death, although it was the factor with the weakest association. Moreover, the recent intake of high doses of inhaled corticosteroids or of oral corticosteroids was a risk factor for COVID-19 related death. In summary, pre-existing asthma increases the risk of intensive care unit admission during SARS-CoV-2 infection, and severe asthma is a risk factor for COVID-19 related death. One important aspect is how asthma should be treated during the pandemic. Inhaled corticosteroids improve asthma control and decrease the exacerbation rate. Moreover, inhaled corticosteroids reduce the expression of ACE2 in bronchial epithelial cells, and this receptor is used by SARS-CoV-2 to invade the bronchial mucosa. The current recommendation states that asthma patients who need inhaled corticosteroids to remain controlled should continue taking them during the pandemic. On the other hand, anti-type 2 biologicals excels in decreasing asthma exacerbations. Actually, omalizumab restores the capacity of bronchial dendritic cells to produce normal levels of type 1 interferons. EAACI guidelines recommend to initiate, in case of indication, or to continue, in case of good response, anti-type 2 biologicals during the pandemic. On the other hand, due to the insufficient understanding of the immune events induced by SARS-CoV-2, EAACI guidelines recommend to stop anti-type 2 biologicals in case of COVID-19. Other important aspect is how we should treat COVID-19 in patients with pre-existing asthma. We have studies showing that the early administration of inhaled or subcutaneous interferons to COVID-19 patients reduces the hospitalization days, speeds up the clearance of the virus from the different tissues, and improves clinical parameters related to the disease. On the other hand, we also have a study showing that the administration of interferon to asthma patients reduces the exacerbation rate. Taking together these two evidences suggests that the administration of interferons, the early administration of interferons, could be a good option to treat COVID-19 in patients with pre-existing asthma. Azithromycin also increases the capacity of bronchial epithelial cells to synthesize type 1 interferons, so this is another potential option to treat COVID-19 in asthma patients. The research priorities in asthma and COVID-19, or also the unmet needs, is a better definition of the asthma phenotype associated with a bad COVID-19 related outcome, and also we need evidence-based recommendations on the use of anti-asthma therapy, including biologicals, during the pandemic and in patients with COVID-19. The pandemic heavily impacted the way chronic diseases were managed, including asthma. To assess the impact of COVID-19 in the management of asthma patients, EAACI Asthma Section conducted a 22-question online survey that was disseminated through EAACI channels to EAACI members and members of peer societies. 339 participants replied to the survey from 52 different countries from Europe, America, Asia, and Africa. Most of the respondents were allergists or pediatricians specialized in allergy who were working in a hospital environment. 41% of the participants were taking care of both adults and children with asthma, 23% of them only of adults with asthma, and 27% of them only of children with asthma. The survey first interrogated about the healthcare adjustments imposed by the pandemic. Face-to-face visits were cancelled for the initial assessment of patients with suspected asthma in 44% of cases, whereas they were cancelled in 90% of cases for the follow-up of asthma patients. In most but not all cases, face-to-face visits were replaced by phone calls. The survey next focused on the performance of lung function tests, especially spirometry. Spirometry was not performed for the initial assessment of pediatric asthma in 56% of cases, the same proportion than for the follow-up of pediatric asthma. Similarly, spirometry was not conducted in the initial assessment of 60% of cases of adult asthma, and it was not performed in 62% of cases of adult asthma during the follow-up. The survey next interrogated about how asthma patients were managed considering the restrictions imposed by the pandemic. For example, how asthma treatment was modified in a patient reported a clinical worsening. The clinical history was used together with lung function tests to modify the treatment in 29% of cases, whereas the clinical history was the only tool to change the treatment in 69% of cases. The survey also focused on the use of ambulatory PEF measurement to monitor asthma control. 56% of the responders encouraged their patients to perform regular ambulatory PEF measurements, whereas 41% of them did not, as they did not consider this test reliable for the daily clinic. Finally, The survey asked the participant to estimate the impact of the restrictions for face-to-face visits and test performance on the quality of healthcare provided and the clinical conditions of asthma patients. Even though the impact was deemed as moderate, on average, highly polarized opinions were observed. In summary, during the COVID-19 pandemic, all necessary efforts should be allocated to ensure lung function test performance for initial asthma diagnosis, whereas PEF measurement should be reinforced for telemonitoring. Thank you very much for your attention.
On World Asthma Day 2021, it is my pleasure to talk to Ioana Agace, EAACI past president and professor of allergy at Transylvania University, who will now tell us about asthma and biologicals. Professor Agace, what are the unmet needs for the application of biologicals in asthma?
There are several unmet needs that we need to consider. For example, the selection of a certain biological, because we have 5 products which target the same overlapping disease phenotypes. Plus, there is a lack of treatment for non-T2 asthma, so all the 5 biologicals, they target only T2. How to define response? What are the strategies to enhance the responder rate? Because unfortunately, the responder rate is only about around 50% for all the biologicals that we have at hand now. What is the duration of the treatment? Because it's a very expensive one, and we need to understand if there is some immune modulation effect so that we can stop treatment without bringing the disease back. What is the regimen used? If the patient comes to the clinic to receive the biological, or it can be home-based, especially during the pandemics. This was an option that we were forced into doing this home-based. And of course, what is the cost effectiveness? As I was mentioning, this is very expensive intervention.
Do patients with severe asthma resemble the population from clinical trials?
Yeah, this is a very good question, and this is something that we need to acknowledge, that usually patients that we are seeing in the clinic, they do not resemble at all the patients from the clinical trials. Just to show you here that the majority in a recent evaluation, the majority are overweight, and you calculate the dose per kilo, so you have to maybe adjust the dose that was tested in the clinical trial. 85% had at least another medical comorbidity, which usually is excluded from a patient which is enrolled in a clinical trial. The second part is extremely important because many of the patients that we are seeing in the clinic have low or very low adherence rates for the background treatment. And this is something that we need to account for when we think of the efficacy of the drug. And also, we must think that you have a higher chance to use a biological if you are middle-aged, if you have high income, so you can afford it, if you have commercial insurance, and if you have access to a specialist to put the diagnosis. So this is major hurdles that we need to consider while developing guidelines for biologicals.
Thank you very much for your answer. Leading on to this, this year EAACI has launched guidelines on biologicals in severe asthma. What new updates do these bring?
Well, there are several highlights that, and these are very much new as a novel approach. Of course, we use the GRADE approaches for the other guidelines, but we decided to formulate recommendations for each biological. So, for example, even if 3 of them target the same pathway, the IL-5 pathway, we did recommendations for each of the biologicals, so we didn't assume a class effect. And we also formulated recommendations for each of the outcomes desired. And this is very important because then, as I will show you a little bit later, when you discuss the efficacy in the clinic, you have to decide which outcome you want to reach. for example, improving lung function or decreasing exacerbations or having a better quality of life. The second highlight, which is we think very useful for the clinician, is a proposed management algorithm that I will share with you in a moment for the use of biologicals in the clinic. And of course, we discuss what could be the future approaches and research priorities with different, let's say, options on how to tackle all these barriers. I will give you one example of how the recommendations are formulated for one of the products that we evaluated. So we formulated different recommendations for each of the outcomes that are there. The second thing is that the population that is addressing the recommendations is very well defined as per the randomized control trials that were used to formulate the recommendations. And last but not least, we offer additional considerations. For example, improving lung function is just a conditional recommendation, so it doesn't have enough strength to recommend it to all the people. But even if the effect size is small, it might be beneficial in patients which have very low function, very low lung function. So we have nuanced recommendations that can be useful again for the clinical decision support.
Thank you very much for this very interesting presentation. So we encourage everyone to read the new EAACI guidelines and also enjoy the World Day of Asthma together with us. Thank you very much.
Yes, and I would like to close, Chiara, by presenting an algorithm for the clinician that we think that it's very can be very useful, and this is one of the novelty that was brought forward by the EAACI guidelines. So, as I was saying, one of the greatest unmet needs is how to choose from all the 5 biologicals and how to measure response. So we said that because there are no prospective trials evaluating this, to use a triple pillar decision combining the phenotypic traits of the patient, so the exacerbation rate, the lung function, as I was showing you, the presence of fixed airway obstruction of comorbidities, in combination with biomarkers and in combination with outcomes that we are willing to achieve and to improve with this treatment. All this triple pillar decision is combined in a shared decision making with the patient, which, because we do not have a threshold, we preset the individual treatment goals in asking the patient what he's willing to achieve in terms of outcomes. So no exacerbations or better lung function, so on and so forth. And with that, we start with the biological that suits best the patient in the outcomes that we want to achieve and in the triple pillar that we are using. We give the treatment for 4 to 6 months. This is again an arbitrary cutoff, but we didn't want to put it too long because it's a very expensive treatment. And we said that after 6 months, we assess response. And we assess response according to the preset individual treatment goals. If the patient is a responder, then we continue by continuously monitoring safety and real-world evidence following pre-specified criteria, which are very well defined, like the registries or the relevant criteria. If there is suboptimal response, then we have to look into the lung, looking at the airway inflammation using induced sputum, and also looking at the airway hyperactivity. If there is no eosinophils left in the lung and we are dealing with neutrophilic inflammation or no inflammation, it makes no sense to continue targeting the T2 pathway. So you stop the biological and you replace with an option for non-T2 asthma, like low-dose macrolides, dual bronchodilators, like for COPD, or in selected cases, bronchial thermoplasty. If there is persistent eosinophilic inflammation, then you do have several options, like checking the adherence for the overall asthma management plan. And this is why the shared decision-making with the patient is extremely important. Usually this is one of the most frequent cases of lack of response because the patient feels so well after the biological that he stops the background treatment, and then his asthma deteriorates. Then eosinophilia might not be driven by the pathway targeted by the biological use, and then you have to switch to a biological targeting a different pathway, or it is inadequate dosing, and then you have to go from subcutaneous to intravenous, for example, or calculate per kilo. It might be the development of neutralizing anti-drug antibodies, and then you have to switch to another biological, or very rarely, but possible, other immune mechanisms involved, and then you have to refer to a specialized clinic. With that, I would like to thank you for the invitation and wish all of you happy World Asthma Day, and let's hope that 2021 will be a good year where we can, with all these guidelines that we are having at hand and with all the medications, we will improve the lives of our patients with asthma. Thank you very much.
Thank you very much.
Hello and welcome to this World Asthma Day presentation. My name is Helen Riddell. I'm Chair of the Global Initiative for Asthma GINA Science Committee, and I'm very grateful to the European Academy for Allergy and Clinical Immunology for the opportunity to give you a brief update about changes in the GINA 2021 strategy report, which was published last week. Just very briefly about GINA, it was established in 1993 with the aim of increasing awareness about asthma and improving asthma prevention and management through a coordinated worldwide effort. GINA is independent and it's funded only by the sale and licensing of its reports and figures. It's a global evidence-based strategy that can be adapted for local health systems and medicine availability. It's very widely used and it has a practical focus with multiple flowcharts and tables as well as evidence presentations. Importantly, the GINA strategy report is updated every year following a twice-yearly cumulative review of new evidence across the whole asthma strategy. So it's not just answers to individual PICO questions. You can find a description of GINA methodology on that website, and you can download a copy of the GINA report and associated resources from the GINA website. First, just a brief update for the GINA guidance about COVID-19 and asthma, and there's a slide set available on the GINA website with more detail than I'm showing here. Firstly, overall, from large meta-analyses, people with asthma do not appear to be at increased risk of COVID-19 or severe COVID-19, although in 2 studies, the risk of COVID-19 death was increased in people with severe asthma, either having needed oral corticosteroids recently or assessed as having severe asthma in hospital. It's important to advise patients with asthma to continue taking their asthma medications, and particularly inhaled corticosteroids, and to make sure that all patients have a written asthma action plan so they can change their controller and reliever medications appropriately if symptoms worsen. And for patients with severe asthma, the current recommendation is to continue biologic therapy or oral corticosteroids if they are prescribed. Obviously, you need to follow strict infection control procedures if aerosol generating procedures are needed, and that includes avoiding nebulizers wherever possible to reduce the risk of spreading virus. And in terms of GINA recommendations about COVID-19 vaccination, GINA recommends patients with asthma should receive a COVID-19 vaccination with the qualifier that obviously the Pfizer, BioNTech and Moderna vaccine shouldn't be given to patients with an allergy to polyethylene glycol or other vaccine ingredients. However, anaphylaxis to food or insect venom or other medications is not a contraindication. Usual vaccine precautions apply, and GINA recommends that COVID-19 vaccinations should be administered on a different day from biologic therapy for severe asthma, and with a gap of 14 days from influenza vaccination. Now I want to move briefly on to the recommendations in GINA 2021 about treatment of asthma in adults and adolescents. Just a reminder about the key change in asthma management in 2019. The treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. This change is because patients with mild asthma are at risk of severe or even fatal exacerbations, that SABA-only treatment increases the risk of severe exacerbations, and adding any inhaled corticosteroids significantly reduces the risk. So GINA now recommends that all adults and adolescents with asthma should receive ICS-containing controller treatment to reduce the risk of serious exacerbations. So this can be either as regular daily ICS-containing treatment, or in mild asthma by as-needed low-dose ICS formoterol taken for symptom relief. Now, in mild asthma, this is what we would call a population-level risk reduction strategy, such as we use with statins and antihypertensives. So individual patients may not necessarily experience or even be aware of a short-term clinical benefit, but the aim is to reduce the probability of serious adverse outcomes at a population level. This is the GINA 2021 treatment figure for adults and adolescents. And at the top, you can see this familiar arrowed circle reminding you of the key steps of asthma management. Assessment, not just of symptoms and lung function, but also of modifiable risk factors, comorbidities, inhaler technique and adherence, and the patient's own preferences and goals. Adjustment, not just of asthma medications, but also treatment of modifiable risk factors and comorbidities, non-pharmacological strategies, and education and skills training. And then review, not just of clinical outcomes, but also of patient satisfaction. Now, the key difference between this figure and the previous ones is that asthma treatments are shown as 2 tracks for clarity. So track 1 is the controller and preferred reliever, and the preferred reliever is as-needed low-dose ICS formoterol. In track 1, the patient uses as-needed low-dose ICS formoterol whenever they have symptoms for symptom relief. And in steps 3, 4, and 5, they are also taking maintenance ICS formoterol as their controller treatment. The reason that this track is preferred is because using ICS formoterol as reliever reduces the risk of exacerbations compared with using a SABA reliever. Track 2 is shown here below, and here the reliever, the alternative reliever, is as-needed short-acting beta agonist. So here in step 1, whenever the patient experiences symptoms, they take a dose of their inhaled corticosteroid whenever they take their SABA reliever. But in steps 2 to 5, the patient is taking either an inhaled corticosteroid or an ICS-LABA maintenance treatment as well. Now, before considering a regimen with a SABA reliever, it's important to check if the patient is likely to be adherent with daily controller, because otherwise they would be using SABA-only treatment. The use of as-needed ICS formoterol in mild asthma is relatively new, and so I just want to briefly go through the evidence that is now available in studies totaling just under 10,000 patients with mild asthma. Compared with SABA alone, as-needed ICS formoterol in mild asthma reduced severe exacerbations by about 2/3 in a large double-blind study in adults and adolescents, and in an open-label study in adults previously taking SABA alone. Compared with maintenance low-dose ICS with as-needed SABA, as-needed ICS formoterol in mild asthma was non-inferior in 2 large double-blind studies and was superior in 2 open-label randomized controlled trials. And this was achieved with an inhaled corticosteroid dose around 1/4 to 1/2 of the dose compared with maintenance low-dose ICS. Then other changes, symptom control, lung function, and FeNO, there were very small differences that did not reach clinical importance and were not cumulative over 12 months. And one study in exercise-induced bronchoconstriction showed no significant difference from regular ICS. Now, the other considerations for as-needed ICS formoterol in mild asthma for GINA were that severe exacerbations can occur in mild asthma, and they're often unpredictable, relating to viral infections, allergen exposure, air pollution, and stress. Inhaled corticosteroids are highly effective in mild asthma, but patients are often poorly adherent, especially if symptoms are infrequent. Importantly, even occasional short courses of oral corticosteroids are now known to be associated with an increased risk of osteoporosis, diabetes, cataract, etc. As I mentioned, the differences in symptom control and lung function were not clinically important. And a final factor was that phenotyping is not needed for treatment with as-needed ICS formoterol. There was no significant difference in treatment effect compared with either as-needed SABA or with daily ICS in patients with high versus low baseline eosinophils or FeNO in 2 studies. I just want to show you 2 additional figures that GINA has provided, including in its slide set, showing suggestions for where to start treatment along these pathways, depending on the patient's presenting symptoms and clinical features. And there are 2 versions of this, depending on the need of education. Some additional changes in the GINA report in step 5 relate to add-on non-biologic therapies. So add-on long-acting muscarinic antagonist in the form of tiotropium has been available for many years, but now in 2021 there are several triple combinations available for patients aged 18 years and older. In the review of this evidence, we found that adding LAMA to medium or high-dose ICS LABA modestly improves lung function, but not symptoms. And in some studies, it modestly increased the time to severe exacerbations requiring oral corticosteroids. However, it's essential that for patients with exacerbations, you should ensure that they receive sufficient inhaled corticosteroids, in other words, at least medium dose ICS LABA, before considering adding a LAMA. The other add-on non-biologic therapy for which there are additional recommendations is add-on azithromycin taken 3 days a week for example, a 6-month period. This, in a meta-analysis, was found to reduce exacerbations in patients with severe asthma that was uncontrolled despite high-dose ICS LABA. And it also reduces exacerbations in both eosinophilic and non-eosinophilic asthma. But before considering this option, you need to check the sputum for atypical mycobacteria, check the ECG for long QT syndrome, and recheck after a month of treatment. And importantly, consider the risk of increasing antimicrobial resistance, either at a population or a personal level. So add-on azithromycin is not recommended as a primary care option. So now moving on to treatment of asthma in children 6 to 11 years. This is the treatment figure for this age group. And again, you can see at the top the arrowed circle reminding you of the importance of personalizing asthma management for children with asthma. And that includes taking into account child and parent preferences and goals, and also their satisfaction with their treatment. So you can see that the treatment steps have several options available in them, and I just want to briefly summarize these. The changes in 2021 are more around making sure that the treatment figure reflects the recommendations in the report. So in summary, in mild asthma, there is substantial evidence for maintenance inhaled corticosteroid plus as-needed SABA in children. But of course, we need to consider the balance of risks and benefits. And in children with infrequent symptoms, taking ICS whenever SABA is taken for symptom relief. There are 2 studies in children and adolescents. Although more evidence is needed, this is probably a good option for children with very infrequent symptoms. In step 3, there are 3 treatment options: low-dose ICS LABA with as-needed SABA, medium-dose ICS with as-needed SABA, and a very low-dose ICS formoterol maintenance and reliever therapy based on this study in children and adolescents. In children, it's important to try options within step 3 before considering stepping up, as there's considerable evidence about variation in response of children within this age group to the different treatment options. Then in step 4, 2 options of a medium dose ICS LABA with as-needed SABA and low dose ICS formoterol maintenance and reliever therapy. But consider referral for these children, particularly if they're having exacerbations because of the risks of asthma in children. I just want to finish by mentioning some things that we're planning to address during this year and will report in future years. So GINA is planning to review the definition of mild asthma to make sure that it's relevant and feasible for clinical practice. We are going to review evidence where we can find it for assessment of symptom control in patients whose reliever is ICS formoterol. We'll be reviewing evidence about subcutaneous and sublingual allergen immunotherapy in patients with asthma, and we will update the advice about COVID-19 as new evidence becomes available through the year. So I'd encourage you to download a copy of the GINA report and the GINA Pocket Guide from the GINA website. There's a lot more detail and many more changes in this report than I was able to cover in this brief presentation. But thank you again to EAACI for the opportunity to speak to you. Thank you.